So already in the first class I have told that the main two parts of the pharmacology is the pharmacokinetics and pharmacodynamics. If you can remember in the Monday class, and then you have started with the pharmacokinetics, and in the pharmacokinetics how the drug when it is taken, how it is absorbed and distributed in our body, it has been held yesterday. Now after absorption and distribution of a drug, what happens to that drug? Ultimately that becomes metabolized or biotransformed. So what is the intention of this biotransformation or metabolism? So that the drug can be eliminated, so that it will be less reabsorbed from different excretory organs, for example kidney. So after absorption and distribution, the drug when it comes to the kidney, so that there will be some transformation in the molecules of the drug should have happened, so that there will be less reabsorption from the kidney again back to the systemic circulation. And most of the metabolite, after metabolism there may be some toxic metabolite or some metabolite that will be excreted from our body. So if there is problem of this metabolism or biotransformation, there will be changes in the pharmacokinetics of the drugs. So there may be toxicity of the drug, or there may be subtherapeutic effect of the drug. So this is the third part of the, after absorption, distribution, metabolism, third part of the pharmacokinetics of a drug. So now let's discuss about this. So biotransformation basically means the chemical alteration of the drug, and the main changes that happens to make it from non-polar to the, you can see from non-polar, usually the drugs are non-polar or lipid-soluble. So non-polar drugs are lipid-soluble. Why it happens? Because our cell membranes are lipoproteinous. So when the drug is lipid-soluble, the drug can be absorbed into the systemic circulation by different types of the cell membranes. So these drugs are non-polar. Non-polar drugs are more absorbed. Okay. So in biotransformation, these non-polar drugs are usually made polar, so that will be lipid insoluble or water soluble, so that there will be more chances of the excretion from the body, so that they will not be reabsorbed in the renal tubules and are excreted. So most hydrophilic drugs, hydrophilic means those drugs that can be absorbed in the water and that is non-absorbable in the lipids. Example, streptomycin, neostigmine, pancuronium, you will all read about these different types of the drugs. These are hydrophilic drugs. So they have little biotransformed and are largely excreted unchanged. So this happens. Mechanisms which metabolize these drugs, essentially these drugs are xenobiotics, that is the foreign substances have developed to protect the body from ingested toxins. So the same types of the metabolism of biotransformation is also necessary to protect ourselves from different types of the toxins. That may be environmental toxins, what we are eating, there may be different types of the toxins that will not be beneficial of our body. All this can be gone through this type of the metabolism pathway and excretory pathways. So what are the sites and results of the biotransformation? The primary site of the biotransformation or metabolism is the liver. So liver is the primary site. In most of the cases, most of the drugs, maximum biotransformation happens in the liver. Apart from this, some biotransformation may happen in the kidney, intestine, lungs as well as the plasma. Biotransformation of the drugs may lead to the three types of the things. One is inactivation. So the drug is already active. Now it is being metabolized or biotransformed so that it becomes inactive. So most drugs and their active metabolites are rendered inactive or less active. Example is the ibuprofen, paracetamol, lidocaine, chloramphenicol, propranolol, etc. This is commonly used. Next is active metabolite from an active drug. That is, after metabolism, the drug is active, the metabolite is also active. Active means that have some biological effects, that have some effect on some tissue, some organs, etc. So many drugs have been found to be partially converted to one or more active metabolite. The effects are observed at the sum total of the parent drug, that is the biological actions of the drug as well as the biological actions of their metabolite. For example, morphine is converted to morphine 6-glucuronide, primidone to phenobarbital, digitoxin to digoxin, imipramine to desipramine, amitriptyline to nortriptyline, codeine to morphine, spironolactone to candidone. These are the main drugs, active drugs, and these are the metabolites. But this metabolism that happens within most of the cases liver, this is also active. They have also some active role. So here the active metabolite from an active drug is formed by means of the biotransformation. And next is activation of inactive drug. This is just opposite of the first one. There are some drugs that are inactive as such, but it has to be activated by means of the biotransformation or metabolism. So these drugs are known as the pro-drug, okay. So few drugs are inactive and conversion in the body to some active metabolite. So product, there are some advantages of a product. For example, they have better bioavailability. The product may be more stable in our gastric juice or intestinal juice, etc. Or other desirable pharmacokinetic properties that may be long acting, less side effects and toxicity. So some products are activated selectively at the site of action. So that product that comes absorbed and distributed in different types of the tissues, and for example, in some tissues we need that drug, and in that tissue some enzyme is there that is converting that product to the active drug. So ultimately that product will not have some adverse effect in some other systems, that is, it is becoming more targeted therapy. So here the activation of the inactive drug happens, and this inactive drug what we are ingesting, this is known as the prodrug. For example, levodopa. Levodopa is converted to dopamine within our body and then it acts. Enalapril is converted to enalaprilat. Dipiveprin is converted to epinephrine. This dopamine, enalapril, epinephrine, these are mainly active ingredients that causes the biological action. Prednisone is converted to prednisolone. Becampicillin is converted to ampicillin within our body. So there are three types of the fates. Already we have seen, that is, the active drug is rendered inactive. The active drug, its metabolite is also active, and inactive drug, it is known as the product, it is converted to the some active metabolite. Now, classification of the two main phases of the biotransformation. There are two phases by which this metabolism of biotransformation happens. One is phase 1, also known as the non-synthetic or functionalization reactions. Here a functional group is generated or exposed. For example, some OH group, SH group, etc. These are added with the drug molecule. This is known as the phase 1 reaction. And phase 2 reaction is the synthetic or conjugation reaction. Conjugation means some endogenous molecules are conjugated, attaches with that molecule. Usually phase 2 reaction happens after the phase 1, but in some of the drugs, phase 2 reaction may precede to a phase 1 reaction. Some drugs directly can go to the phase 2 reactions, there may be no phase 1 reactions like this. So these involve conjugation of the drug or its phase 1 metabolite with an endogenous substrate. For example, some protein or some amino acid is already present in our body that is attaching with that drug. Usually derived from carbohydrate or amino acid to form a polar highly ionized organic acid which is easily excreted in urine or bile. So biotransformation phase 1 and phase 2. First coming to the non-synthetic or phase 1 reactions. The most common non-synthetic or phase 1 reaction is the oxidation reaction, that is oxidation of the drug molecule happens. Here addition of some oxygen or negatively charged radical happens, or removal of hydrogen or positively charged radical happens. This you know from the chemistry, that when we are adding some negatively charged radical or removal of the positively charged radical, it becomes oxidized. And the most important drug metabolism reaction is the oxidation, and this oxidation may happen by different types of the reactions. For example, there may be hydroxylation, there may be oxygenation at C, N or S atoms of that drug molecule, N or D, O, dealkylation, oxidative deamination, etc. These are the different types of the chemical reactions that ultimately leads to oxidation of the drug. In many cases, the initial inclusion of that oxygen may lead to the formation of some unstable molecules that may happen due to the superoxide radical. So highly reactive quinone or epoxide or superoxide intermediates may be formed, and then it is converted to some stable compound. So this is the way by which the oxidation of the drug happens. Now coming to the cytochrome P450. This cytochrome P450 is the most important enzyme that is involved in the oxidation of the drug. Now this cytochrome, it means these enzymes are usually present within the cytoplasm near to the cell membranes. That's why cyto. And chrome means they mainly have some different types of the pigments, most commonly heme pigment. And P450 means this is the wavelength of the light. When it is exposed to some carbon monoxide, they usually absorb light of the 450 nanometer. So by means of this light wavelength, we can differentiate different types of the enzymes. That's why it is known as the cytochrome P450. This cytochrome P450 mainly carries out most of the oxidative reactions of the drugs. And there are different isotypes of the cytochrome P450, but mostly the cytochrome P450 1, 2 and 3. These three types mainly controls 90% of the drugs oxidation reaction in our body. And within this 1, 2, 3, there are different types of the subtypes also. For example, there may be 1A1, 1A2, 1A3 like this. So it is mainly present in the liver. It is the final step, involves cytochrome P450 hemoprotein, NADPH, cytochrome P450 reductase, molecular oxygen. So these are the different ways by which the oxidation happens. More than 100 cytochrome P450 isoenzymes are there, but mostly what I have already discussed, that is usually it is designated by the numerals 1, 2, 3, then subtypes ABC. Again, it is more subtypes like 1, 2, 3, etc. In humans, mainly cytochrome 1, 2 and 3 carry out most of the chemical reactions. So you can see this is the cells, this is the endoplasmic reticulum, nucleus, mitochondria and cytoplasm. And near that cytoplasm, near the endoplasmic reticulum, you can see there is oxidoreductase, this cytochrome P450 complex is present. And if we can zoom in to this complex, you can see within this complex there is ferric iron, that is the heme. This Fe and SO is present, that is like a heme pigment, pigmentation is there. And there are different other chemical reactors like NADPH, etc. that helps in this oxidation reaction. So this is the molecular structure of the cytochrome P450 oxidoreductase system. And within this iron protoporphyrin 9 or heme iron is present within this one. Okay. So this is present within our cells, in most of the cases liver, but it is also present in some of the lung tissue, also in the kidney tissue, some intestinal tissues, etc. Within the liver or in these tissues, in the cytosol near to the endoplasmic reticulum, this cytochrome P450 oxidoreductase system is present. So most of the cases cytochrome P3A4 or 3A5, we can call it cytochrome P450 3A4/5. This handles approximately 50% of the oxidation reaction of all the drugs. So mainly just remember cytochrome P450 3A4 or 3A5, 3A4/5. More than 50% of the drugs are mainly metabolized by this type of the enzymes. It is expressed in liver, intestine and kidney. Inhibition of this isoenzyme by erythromycin, clarithromycin, ketoconazole, itraconazole is responsible for the important drug interactions with terfenadine, acetaminophen and cisapride. That means when they are metabolized by this enzyme, there may be some other drugs that is also metabolized by this enzyme. So some drugs can inhibit the actions of the cytochrome P450 system. Some drugs can induce the actions of the cytochrome P450 system. When two drugs are given, both are metabolized by the cytochrome P450 system, they can compete with each other. So all this leads to different types of the interactions. There may be drug-drug interactions. There may be variability in the drug response from one individual to another. This is mainly controlled by different types of the genes. More than one genes are there, and there are changes in the genes that leads to the changes in the subunits of the cytochrome P450 system. This is known as the genetic polymorphism. So that's why the same drug may be metabolized in one individual in one way, in another individual in another way. The same drug may be more metabolized in one individual so that their effect may be less, since they are more metabolized. In another individual, that same drug may be less metabolized. That's why there may be availability of that drug for long period of time. There may be toxicity. So all these are controlled by the cytochrome P450 system and their genes. That's why different individual drug-drug variability happens, drug-drug interaction happens. And there are different types of the drugs that can act as a cytochrome P450 inhibitor or cytochrome P450 inducer. So when we are prescribing one drug, for example, we are prescribing 3 drugs, and within these 3 drugs, one drug can induce the cytochrome P450 system, and that's why there may be more metabolism. And another drug is also metabolized by that system. So there may be some subtherapeutic effect. That drug cannot act. Similarly, some drugs that can inhibit it, there may be toxicity. So when we are prescribing, we have to keep in mind that these drugs are inducer, most common inducer, or this drug is the most common inhibitor. So we should not give these two drugs or these three drugs together. There may be some drug-drug interactions that leads to different types of the adverse drug reactions. Okay, that's why we need to know about this metabolism and cytochrome P450 system. So losartan, nifedipine, hydrocortisone, mifepristone, these are different types of the examples. Just you have to keep in mind that these can happen, that different types of the interactions. So these all are metabolized by the cytochrome P450 3A4/5, most of the drugs. These are the other groups of the drugs like verapamil, diltiazem, ritonavir, etc. These are the inhibitors of this cytochrome P450 system. While rifampicin, barbiturate, other anticonvulsant, they are the inducer. Inhibitor means they are inhibiting the metabolism of the other drugs at that system, and inducer means they are more metabolizing other drugs at that system. That's why inhibitor and inducer. So cytochrome 2D6 is the next one important, approximately that handles 20% of the drug metabolism. So most important is the 3A4/5. Next is the 2D6. These two, okay, 2D6. Approximately they metabolize different types of the tricyclic antidepressants, selective serotonin reuptake inhibitor. We will read all this later. Different neuroleptics, antiarrhythmics, beta blocker, opioids, etc. So if we are inhibits this cytochrome P450 enzyme, like for example quinidine, that results to failure of conversion of codeine to morphine. So previously we have seen codeine is converted to morphine, which is the active ingredient. So analgesic effect of the codeine is lost. This is just example. For example, we are giving codeine as well as the quinidine in the same prescription. Now what happens? Quinidine, it is the inhibition of the enzyme happens, and this enzyme is necessary for the activation of this codeine to morphine. So here it is just opposite. Here we are inhibiting the enzyme, but inhibiting the enzyme means this enzyme is also necessary for converting one drug that is a product to an active drug. Codeine is a product, we are converting it to active drug, and this is done by the cytochrome P450 system. Now we are giving this quinidine. So quinidine blocks this, that's why this codeine cannot be converted to morphine. And this morphine, for example, this is needed for in case of the cancer pain. It is a very good analgesic, most commonly in cancer pain it is used. Now in the same patient, if we are giving these two, the patient can complain that my pain is not relieved because it is not converting to morphine. That's why no biological effect. This is just example. So human subjects can also be grouped into extensive or poor metabolizers of the different drugs like metoprolol, for example. This is commonly used. So these also controlled by different types of the genes. Our genes may be such that some drugs we can be called that extensive metabolizer of some drugs. And the same drug may be poorly metabolized in some other individuals. So there may be some extensive metabolizer, poor metabolizer, all these are controlled by the genes, genetic makeup. So poor metabolizers have an altered cytochrome P2D6 enzyme and exhibits low capacity to hydroxylate many drugs. Low capacity, poor metabolizer, metabolism will be poor. There will be low hydroxylation, that is low oxidation. So ultimately the drugs may be remain in our system for a long period of time and give different types of the untoward reactions. So this may happen. Next is cytochrome 2C8/9. It is mainly used as a metabolizer in case of the phenytoin, carbamazepine, warfarin, etc. CYP2C19 is another cytochrome P450 system that metabolizes greater than 12 frequently used drugs like omeprazole, lansoprazole, etc. Phenytoin also, you can see phenytoin, here is also phenytoin. So there are some drugs that are metabolized by more than one types of the cytochrome P450 enzymes. That may happen. Rifampicin and carbamazepine, these are the potent inducer of the different types of the cytochrome family in fact. See, rifampicin and carbamazepine, these two are very commonly used. You will see in different types of the drug interactions later also, because these are the very commonly known drug cytochrome P450 enzyme inducer. So when these are used, there may be subtherapeutic effect of the other drugs that may happen. Cytochrome 1A1 or 1A2, they also causes metabolism of the some other drugs like theophylline, paracetamol, carbamazepine, etc. Apart from this, you can see some other xenobiotics, for example, cigarette smoke, different types of polycyclic hydrocarbons. These are also can be metabolized by these. Another is 2EU1. Different other drugs can also be metabolized by this. Details is not required. Now, after the oxidation, next coming to the reduction. So, within the oxidation, you have to remember about the cytochrome P450 system and its importance. Next, reduction is the just opposite of the oxidation, involves cytochrome P450 enzymes working in the opposite direction. So, mainly alcohol, aldehydes, quinones, they are mainly reduced. Their biotransformation mainly happens by reduction mechanisms. Drugs primarily reduced are the chloral hydrate, chloramphenicol, halothane, warfarin, etc. So, after oxidation, there is reduction. Next, coming to the hydrolysis. Hydrolysis means ester plus water. By esterase, it is converted to acid plus alcohol. So, they are taking up a molecule of the water. So, there will be lysis, hydrolysis. Different amides and polypeptides are also hydrolyzed by the amidases and peptidases. This is also present in our body. There may be epoxide hydrolases which detoxify epoxide metabolite of the some drugs that are generated by the cytochrome oxygenase. So, previously by oxygenation, there may be some epoxide generation may happen in some of the drugs. Again, some hydrolysis can happen. So, it is not just a one reaction. So, there may be some multiple cascade type of reaction. So, by means of the cytochrome P450 system, some metabolites are formed. Again, some hydrolysis happens so that it will become non-toxic. So, hydrolysis occurs again in the same areas: liver, intestine, plasma, different types of the tissues. Cholinesterase, procaine, lidocaine, procainamide. So, these are the different drugs that are mainly metabolized by hydrolysis. Apart from this oxidation and different types of the oxidation reactions already we have seen and hydrolysis, there are some other phase 1 reactions lesser used now, like cyclization, that is cycle is formed in the structure, or decyclization, that is the chemical structure is already some cycle, like benzene ring is present, that ring is opened up. So, these are the different ways by which the different drugs are biotransformed. So, like cimetidine, ranitidine, clozapine. So, they may be oxidized at some other areas like NP or S atoms by flavin monooxygenase. So, another group of the enzymes, flavin monooxygenase, can also be involved in biotransformation. They are not susceptible to induction and inhibition by other drugs and are not involved in drug interactions. So, drug interactions mainly involve the cytochrome P450 system. Some drugs like adrenaline, alcohol, mercaptopurine, they are mainly oxidized by mitochondrial or cytoplasmic enzymes. So, next coming to the phase 2 reactions. So, phase 1 reactions mainly functionalization reactions where different functional groups are added. Now, in phase 2 reactions synthetic, that is already some endogenous groups or endogenous component is present that is added to the drug. The most common is the glucuronide conjugation. Within the phase 1, the most common is the oxidation reaction, and within the phase 2, the most common reaction is the glucuronide conjugation. So, this is done by this enzyme UDP glucuronylyl transferase. So, UDP glucuronylyl transferase mainly carries out this glucuronidation reaction where the compounds with hydroxyl or carboxylic acid groups, they are conjugated with glucuronic acid that is already present in our body, and this glucuronidation happens. Example of the drugs like chloramphenicol, aspirin, paracetamol, diazepam, lorazepam, they undergo this type of the glucuronidation reaction. Apart from these drugs, some endogenous molecules that is already present in our body like bilirubin, different types of steroid hormones, thyroxine, their metabolism is also carried out by this glucuronidation mechanism. Glucuronidation increases the molecular weight of the drug which favor its excretion in the bile. That is, they may be excreted in the bile, there may be some enterohepatic circulation also. So, drug glucuronides excreted in the bile can be hydrolyzed by bacteria in the gut. Within our gut, there may be commensal bacteria that can hydrolyze that drug or some xenobiotics or some endogenous material within the bile. The liberated drug is reabsorbed and undergoes the same fate. So, this is the way, that is, they may be excreted in the bile, they may be excreted in the stool by which they can be excreted. Apart from the glucuronidation, the most important reaction, there may be acetylation, where the amino hydrogen residues are conjugated with the help of acetyl coenzyme A. So, acetyl coenzyme A can be beneficial here. Example is sulfonamides, isoniazide, dapsone, hydrolazine, clonazepam, they can be acetylated. So, multiple genes control these acetylases also, N-acetyl transferase. So there may be genetic polymorphism. Already what I have previously said, genetic polymorphism is also there in the cytochrome P450 system. It is present in different other this machinery also, like this acetylation, and there may be fast acetylator, slow acetylator also. You will read about this when you read different drugs. So there may be some individuals who are fast acetylator, that is in them the acetylation reaction will be more, the drugs will be metabolized more. For example, you can see that these drugs, this sulfonamide is an antibiotic. In fast acetylator, there may be more metabolized. In slow acetylators, there may be less metabolized, like this. Next, coming to the glutathione conjugation. Glutathione group is added. Hence, here it is caused by the glutathione S transferase, another enzyme. It serves to inactivate highly reactive quinone or epoxide intermediates formed during metabolism of certain drugs, example paracetamol. So, when large amounts of such intermediates are formed, like in poisoning or enzyme induction, glutathione supply may be less. So, toxic adducts are formed within tissue constituents and tissue damage happens. So, what happens when this glutathione cannot be added with this? So, there may be some toxicity. So, we have to supply or replenish the glutathione group. This may happen in some of the poisoning. For example, paracetamol poisoning. When there will be paracetamol poisoning, these glutathione groups will be depleted. That is, no glutathione in our body is there to make up the poisoning effects of the paracetamol. So that we have to add some other drugs or we have to do some other things so that there will be replenishment of this glutathione group, so that this glutathione can render the paracetamol, more amount of the paracetamol from the toxic to the non-toxic ones. This is an example. So, glutathione conjugation, another one. Other conjugation reactions are methylation, where the methyl group is added. Sulfate conjugation, sulfate group is added. Ribonucleoside and nucleotide synthesis. The newer synthesis of some ribonucleoside or ribonucleotide groups can happen. These are some mechanisms by which different drugs can be metabolized. But the most important is the glucuronidation reaction. After the glucuronidation, the most important is the acetylation and the glutathione conjugation. So, you can see, so there may be simultaneous as well as the sequential biotransformation or metabolism in the drugs. So, in the first, I have said that there will be no same way that first phase 1 will happen, next phase 2 will happen. So, the drugs may go to the phase 1, then directly it may be excreted. The metabolite can undergo the phase 2 reaction and this metabolite can be excreted, or some drugs can be directly go to the phase 2 reactions and then they can be excreted. So, you can see this is the endogenous molecule that is added in the phase 2 reaction. So, this is the main difference between the phase 1 and phase 2 reaction. In phase 1 reaction, this is the functionalization reaction where some functional groups are added so that there may be oxidized or reduced like that. In phase 2 reactions, some endogenous molecules are added, like that may be glucuronide, that may be glutathione, that may be acetyl coenzyme, etc. So, that is the difference between the phase 1 and phase 2 reactions. So, drug metabolism, most drugs are metabolized by many pathways. So, like that is only this glutathione conjugation happens to this drug. The drug may be conjugated by the glutathione as well as the glucuronide also, that may happen. Rates of the reaction by different pathways often vary considerably. So, there may be heterogeneous. A variety of the metabolites, some more, some less of a drug may be produced. So, this is to give you an idea about how the drugs are metabolized. This is no a common way is there. So, there may be some stereoisomers, there may be levoisomers, there may be dextroisomer. You have read in the biochemistry, levo and dextroisomer. They may be metabolized separately. There may be such that some levoisomer will be more metabolized, dextroisomer will be less metabolized. That may happen. It happens, for example, in the warfarin. Warfarin is an anticoagulant, you will read later. This S-warfarin rapidly undergoes ring oxidation, while R-warfarin is slowly degraded by the side chain reduction. That is different ways by which they are metabolized. Only a few drugs are metabolized by enzymes of the intermediary metabolism, like alcohol by dehydrogenase reaction, allopurinol by xanthine oxidase. That is, apart from this main phase 1 and phase 2, there may be some intermediary enzymes may be there that may changes something in the constituent of that drug. That may happen like this alcohol or allopurinol. Okay. So, majority of the drugs are acted on or by relatively non-specific enzymes which are directed to types of the molecules rather than to specific drugs. That is, similar types of the molecules can be metabolized by the similar types of the enzymes. Drug metabolizing enzymes can be divided mainly into two types. What we have already discussed, like microsomal enzymes. Microsomal enzymes is the Cytochrome P450. They mainly located on the smooth endoplasmic reticulum, primarily in the liver, also in the kidney, intestine, mucosa and the lungs. Examples are the monooxygenases, Cytochrome P450, UGTs, that is the already glucuronide conjugation happens, this epoxide hydrolase. These also are the microsomal enzymes. That is different phase 1 reaction enzymes as well as the phase 2 reaction enzymes may be microsomal enzymes. They catalyze most of the oxidation, reduction, hydrolase and glucuronide conjugation. Microsomal enzymes are inducible by drugs, that is drug-drug interactions can happen. Already we have discussed by diet also, because the diet also contains different types of the materials. They contain different types of the chemical constituents. Some drugs, for example, different types of the vegetable contains phosphate group. So there may be some drug-drug interactions, drug-food interactions also. Non-microsomal enzymes means they are present in the cytoplasm and mitochondria of the hepatic cells as well as other tissues and also in the plasma. Example is esterase, amidase, some flavoprotein oxidase and most of the conjugates. These are the non-microsomal enzymes. They mainly catalyze some other oxidation reaction, reduction reaction, some hydrolytic reactions and almost all conjugations except the most common conjugation, that is the glucuronidation. So glucuronidation mainly caused by the, again the microsomal enzymes, again they can be induced or inhibited, but the other types of the conjugation reactions are mainly carried out by the non-microsomal enzymes. These non-microsomal enzymes are usually not inducible, but many show genetic polymorphism. So they are not induced by the other drugs. There may not be drug-drug competition, but there may be genetic polymorphism. That is, one individual genetic makeup and another individual genetic makeup may leads to the different types of the expression of these different types of the enzymes. Both microsomal and non-microsomal enzymes are deficient in the newborn. Mainly in the newborn and also in the premature infants, these microsomal and non-microsomal enzymes are not there, like chloramphenicol, opiates, etc. That's why all drugs cannot be given to them, even if in the minute quantities. So this deficit is made up in the first few months. So ultimately there will be development. With the development of the baby, there will be development of these different types of the enzymes is also there. More quickly in case of the oxidation and other phase 1 reactions than in case of the glucuronide, because this oxidation reaction, the cytochrome P450 is very important for the survival, because all the different types of the xenobiotics are already introduced to the baby. Whenever the baby is there, baby is taking some outside food, there will be introduction of different types of the other materials. So they have to be metabolized. That's why. The amount and the kind of drug metabolizing enzyme is controlled genetically. Time and again I am saying all these are controlled by the genetics and is also altered by the environmental factors, different types of the environmental pollutants also. So marked interspecies and inter-individual differences are there. Interspecies difference is also there. So the same drug will not behave in the same South Asian population as well as in the European population. It happens. The same drug have to be given in different doses in the American population, in some Vietnamese population, like this, because the genetic makeup is separate. That's why the metabolism way of the elimination is also different, and also inter-individual, from one individual to another individual. So these differences there. Another ways by which metabolism happens, this is a unique mechanism known as the Hoffman elimination. Hoffman elimination, this is basically inactivation of the drug in the body by spontaneous molecular rearrangement. That is, there is no outside enzyme is involved, the drug is already there and their molecules are spontaneously rearranged after their effects are gone. So spontaneous molecular rearrangement happens without the agency of any drug. This is known as the Hoffman elimination. This is particularly and precisely is seen in case of the atracurium. This atracurium drug shows Hoffman elimination. Okay. So this is giving you a nutshell about the different enzymes and their reactions. For example, cytochrome P450 already we have discussed. They give rise to different types of the oxidation reactions like C and O oxidation, dealkylation, etc. There may be flavin monooxygenases we have seen. They causes different types of oxidation reaction. Epoxide hydrolase, they causes hydrolysis. Phase 2 reactions like UDP glucuronyl transferase, that mainly causes addition of glucuronic acid. Sulfotransferase, they causes addition of sulfate. Glutathione S transferase, already we have discussed, they causes addition of the glutathione group. N-acetyl transferase causes addition of acetyl group. Methyl transferase causes addition of the methyl group. And some other enzymes, some miscellaneous like alcohol dehydrogenase causes reduction of alcohol. Aldehyde dehydrogenase causes reduction of the aldehyde. There may be NADPH quinone oxidoreductase that causes reduction of the quinones. This is already we have discussed. So, this is to give you a nutshell about different types of the phase 1 reactions and phase 2 reactions. Now coming, already we have discussed about the inhibition and induction of the drug metabolizing enzymes. Already we have discussed. Now let's see about this. So one drug can competitively inhibit the metabolism of another if it utilizes the same enzyme and cofactor. Already we have discussed. So that the same, for example, same cytochrome P450 3A4 is there. There are two drugs that are metabolized by the same enzyme. So they may compete with one another. Okay. So drug may inhibit one isoenzyme while being itself a substrate of the another isoenzyme. That is, the drug is metabolized, for example, cytochrome P450 3A4 and it is metabolized by the 2D6. So this may happen. There are different types of the drugs. Example, quinidine is metabolized mainly by the cytochrome P3A4 but inhibits cytochrome P2D6. So another drug that is metabolized by the cytochrome P2D6, there may be some drug-drug interactions. Clinically significant inhibition of the drug metabolism occurs especially if they are metabolized by the saturation kinetics or if kinetics changes from the first order to zero order over the therapeutic range. So you will read about this, you have already read about the first order kinetics and zero order kinetics. You will read about this in the next class. So there is known as the saturation kinetics. In most of the drugs, the drug-drug interactions will be more when the drug is saturated in being eliminated. Inhibition of the drug metabolism occurs in a dose-related manner. That is, to increase dose, there may be increased elimination. Mainly it happens in the first order kinetics, but in the zero order kinetics, there may be more accumulation. So can precipitate toxicity of the object drug? Can happen. Because enzyme inhibition occurs by direct effects on the enzyme, it has a fast time course. That is, within hours, enzyme inhibition can happen. That is, they are giving, they are blocking. That's why the another drug cannot be metabolized by this, and this may happen within hours. Metabolism of the drugs with high hepatic extraction dependent on liver blood flow limited metabolism, it is known as. That is, liver, there is blood flow. In the liver, when there is high blood flow, high liver blood flow, high hepatic extraction is seen. Example, propranolol reduces the rate of lidocaine metabolism by decreasing the hepatic blood flow. So one drug can decrease the hepatic blood flow and then again the metabolism may be diminished. Drug-drug interaction. Some other drugs whose rate of metabolism is limited by hepatic blood flow are morphine, propranolol, verapamil and imipramine. It means the hepatic blood flow is needed because the drug has to enter within the hepatic cells by means of the hepatic blood flow. Then within the cells there are cytochrome P450 system, other systems are there, glucuronide, etc., etc. So there may be some drugs that can increase or decrease this hepatic blood flow also and ultimately controls the metabolism of the another drug. So drugs that inhibit the drug metabolizing enzymes, that is, these are the inhibitor. These are the metabolism inhibitor drugs most commonly, like allopurinol, omeprazole. Omeprazole is a proton pump inhibitor, very commonly used when there is some dyspepsia or acidity. So this omeprazole, you can remember, it is a drug, it is an inhibitor of the drug metabolizing enzyme, most common. Chloramphenicol is an inhibitor. Ketoconazole is an antifungal drug which is a very commonly known inhibitor of the drug metabolizing enzyme. Metronidazole, it is used in amoebiasis. When there is dysentery or amoebiasis, many of you have ingested the metronidazole, metronidazole. That is also a drug inhibitory effect is there. There are some different other drugs are there. Details is not required. Remember some names, that is most common name like allopurinol, omeprazole, erythromycin, chloramphenicol, ketoconazole, metronidazole, ciprofloxacin also most commonly antibiotic. These are the inhibitor of the drug metabolizing enzymes. Now coming to the inducer. So now we have discussed about the drug inhibitor, inhibiting the drug. Now inducer, inducing the drug, that is more metabolism of that happens. So many drugs, there may be some insecticides, there may be some carcinogens, environmental pollutants. They interact with DNA and increase the synthesis of the microsomal enzyme protein. That is more synthesis of the cytochrome P450, more synthesis of some other metabolizing enzyme like UGTs, etc. So as a result, there will be more induction. Their rate of metabolism of the inducing drug itself and the other drugs is increased. So it may happen they are itself metabolized by that enzyme, they are also inducing this, and they are also inducing the metabolism of the other drugs that is also given, that is also metabolized by the same type of the enzyme. Only example is the different types of the anticonvulsant drug. Anticonvulsant drugs means those are used in epilepsy, anti-epileptic drug. For example, phenobarbital, phenytoin, carbamazepine. These are the very commonly drug that is the metabolizing enzyme inducer. Rifampicin or rifampin, this is an antibiotic. Glucocorticoids, they mainly induce the cytochrome P450 enzymes, 3 enzyme isoenzymes. Phenobarbital also induces B1 and D6. Isoniazid and chronic alcohol consumption induce the cytochrome P450 2E1. Chronic alcohol consumption also induces the metabolism of different types of the drugs. Polycyclic hydrocarbons, different types of the polycyclic hydrocarbons are present in different types of the cigarette smoke, charcoal broiled meat, etc. Omeprazole, industrial pollutants, etc. They all induce the cytochrome P450 1A isoenzymes. So from this you can see that these are the different drugs or environmental pollutants that changes the metabolism of the other drugs. Other important enzyme inducers are phenylbutazone, DDT, griseofulvin, etc. Phenobarbital, for example, induce both this 3A as well as the 2D isoenzymes. And you know this 3A 4/5 and 2D6, they mainly controls 50 plus 20, approximately 70% of metabolism of all the drugs. So there may be problems with this phenobarbital. Phenobarbital already we have seen is an anti-epileptic type of drug or sedative hypnotic type of drug. Induction of the polycyclic hydrocarbons again, that is present in the cigarette smoke, that may causes different types of the problems whose are metabolized by the cytochrome P450 1A enzymes. Induction involves microsomal enzymes in liver as well as other organs and increases the rate of metabolism by 2 to 4 fold. That is very highly increased. And but induction takes approximately 4 to 14 days. Induction usually takes time, but inhibition of the drug metabolizing enzyme is the immediate. It happens within hours, but it usually takes approximately 4 to 14 days to reach its peak and is maintained till the inducing agent is being given. Thereafter, the enzyme returns to their original value over 1 to 3 weeks. That is a long process. That is, if some 2 drugs are given, there may be some problems of drug-drug interaction, enzyme induction happens. Even if we are stopping the drug, it takes approximately 14 days and another 14 days, approximately 1 month to reach to its normal position. What are the consequences of this microsomal enzyme induction? Decreased intensity and the duration of the action of the drugs that are inactivated by metabolism. Their actions will be less. Example, failure of the contraception with oral contraceptives. So, if a patient is taking some oral contraceptive pill and she is also taking some rifampicin. Rifampicin is used, for example, in the tuberculosis. So, what happens is rifampicin ultimately causes the induction of the metabolism of this oral contraceptive pill, so that there will be more metabolized, so their actions will be less. Now, oral contraceptive pill, the main it is given to prevent the pregnancy. So, when their metabolism will be more, their effects will be less. This is known as the subtherapeutic effect. So, subtherapeutic effect means there will be no effect, there may be pregnancy may happen. So, this is one example of drug-drug interactions. Increased intensity of action of the drugs that are activated by metabolism. So, in the past we have seen that some prodrugs may be activated by the metabolism. So, if we are giving some inducing agent and this is a product, so there will be more active drugs are generated. So, there again there may be some problems of toxicity that may happen, like acute paracetamol toxicity may happen like this. Tolerance can develop, that is if the drug induces its own metabolism, that is we are giving some drugs and then we are increasing the dose, but the effect will not be evident in that person because the drug is metabolized more. That is why more and more dose is needed for the same type of the effect. That may happen. This is known as the tolerance of the drug. That may happen. Some endogenous substance like steroid, bilirubin, they are also metabolized faster. So, there may be some other problems in the endogenous metabolism also. Precipitation of the acute intermittent porphyria can happen because this porphyria may happen. Porphyrin synthesis happens by means of one enzyme. When this induction is happening, there may be some changes in this enzyme. This is delta amino libulinic acid synthase. So, there may be precipitation of the intermittent porphyria that may happen. Intermittent use of an inducer may interfere with adjustment of dose of another drug. Already we have discussed about the oral contraceptives, like oral anticoagulants are there, antihypertensives, oral hypoglycemics are there. So if we are intermittently given some drugs that hamper their metabolism, we cannot increase or decrease the dose. We do not know if the person is not responding to the drug, whether we should increase the dose, because increase the dose may lead to adverse effect also, or whether we have to stop the another drug that causes the induction of the drug. But if we do not know about this thing, that this drug is inducing the metabolism of another, we will not stop the drug and we keep on increasing the dose of the another drug. That ultimately leads to problem. So interference with chronic toxicity testing in animals. So when a drug comes to the market, different types of the testing is done in the animals that can also be interfered with. So drugs whose metabolism is significantly affected by enzyme induction are phenytoin, warfarin, imipramine, oral contraceptives. Already I have given example, these are. So there may be problem with these drugs when induction happens. There may be some possible uses of the enzyme induction, like congenital non-hemolytic jaundice. It is due to the deficient glucuronidation of bilirubin. Phenobarbital hastens clearance of the jaundice. So if there is some already accumulation of some endogenous molecules within the baby or within some body of adult person, we can give some drug metabolizing inducing drug so that there will be more induction. So ultimately that can have some beneficial therapeutic effects also, like in case of the congenital non-hemolytic jaundice. Cushing syndrome. Here also phenytoin may reduce the manifestations by enhancing degradation of adrenal steroids which are produced in excess. Some chronic poisoning cases by faster metabolism of the accumulated poisonous substance and also liver disease. So here we are taking help of this accelerated induction of the metabolism so that there will be helpful in these different types of the syndromes like congenital non-hemolytic jaundice, Cushing syndrome, chronic poisoning and liver disease. Now lastly coming to the another concept, that is the first pass metabolism or pre-systemic metabolism, first pass metabolism. What is this? Metabolism of a drug during its passage from the site of absorption into the systemic circulation. So when it is absorbed, for example absorbed from the intestine or absorbed from the stomach, and then it comes to the systemic circulation, within this, when it passes through this, there may be some metabolism, first pass. This is known as the first pass metabolism. So all orally administered drugs are exposed to the drug metabolizing enzymes in the intestinal wall and liver. So this first pass metabolism mainly happens in the metabolizing enzymes that is present in the intestinal wall and most importantly in the liver. So most common site is the liver for the first pass metabolism. Pre-systemic metabolism in the gut and liver can be avoided by administering the drug through sublingual, transdermal or parenteral routes. So if we want, so that drug, the bioavailability will be more. We do not want their first pass metabolism, so that most of the drugs will reach its destination. There may be some acute situation, then we can give some drugs so that this first pass metabolism or pre-systemic metabolism can be bypassed. And this bypassing can be done if we are giving that drug by parenterally, that is by injection. That may be given by venous blood, by intravenous route. That may be given by transdermally, transdermal patch can be given. So the extent of the first pass metabolism differs for different drugs and is an important determinant for oral bioavailability. For oral drugs, there will be bioavailability. Already we have seen in the previous class. Bioavailability means that part of the drug that is ultimately becomes helpful for absorption. So when orally administered drug is given, some part is gastric juice that is destroyed, some part goes to the liver that is also destroyed. So oral availability of the drugs, it is made such that higher dose is given so that that amount of the drug that is needed for the treatment will reach the destination. And when it is given transdermally or when it is given intravenous or intramuscular, the most of the drug will reach to the site. For example, for intravenous route, the bioavailability is 100% because we are injecting the drug within the blood itself. That is, the bioavailability is 100% for the intravenous drug. But when we are giving some oral drug, the bioavailability will not be 100%. Maximum it can be 99%, 98% like this. So extent of the first pass metabolism also differs between different types of the drugs. So that some drugs are having more first pass metabolism, some drugs are having less first pass metabolism. That is, low first pass metabolism happens for phenobarbital, phenylbutazone, theophylline, isosorbide mononitrate, etc. Intermediate example is aspirin, nortriptyline, metoprolol, etc. And these are the high first pass metabolism drugs. and these cannot give orally because the fast pass metabolism such that will not be reach anything, that is approximately 0% will happen, like isoprenaline, lidocaine, hydrocortisone, testosterone injection. These are not given orally at all, and high oral dose is needed for these drugs like propranolol. Propranolol is a beta blocker, alpranolol, verapamil is a calcium channel blocker, salbutamol is used in asthma, glyceryl trinitrate used when there is some angina, morphine, pethidine, here high oral dose is needed. So fast pass metabolism also determine in which route we have to give the drug, in which dose we have to give the drug. So attributes of the drugs with high fast pass metabolism. So which of the drugs we can predict that they have high fast pass metabolism? So here the oral dose is considerably higher than the sublingual or parenteral dose. Also sublingual route when it is given, also the bioavailability will be more. We are bypassing the fast pass metabolism. There is marked individual variation in the oral dose due to differences in the extent of the fast pass metabolism. This happens for this drug. Oral bioavailability is apparently increased in patients with severe liver disease. When there is severe liver disease, the liver enzymes will be less, so that the metabolism is also less, so that this drug will be more available in our body when there is liver disease. Oral bioavailability of a drug is increased if another drug competing with it in the fast pass metabolism is given concurrently. Same thing, drug-drug interactions. Example, chlorpromazine and propranolol. Both are given. So oral bioavailability of one drug is increased if another drug competes it in its fast pass metabolism. That may happen. So you can see a graph. This is the phase 1 enzymes and this is the phase 2 enzymes. So you can see the most of the phase 1 reactions already we have discussed. It is done by the difference of the cytochrome systems, and then there are some other enzymes that is utilized in the phase 1 reactions. In most of the cases, the glucuronidation and also some other conjugation reactions that is involved in the phase 2 enzymes. Again the same thing, time and again I am saying, phase 1 reactions and phase 2 reactions, the fractions of the clinically. So to conclude, remember phase 1 reactions mainly involve the oxidation. Apart from oxidation, there may be reduction, hydrolysis, etc. They usually form more chemically reactive products which can be pharmacologically active, that may be toxic or carcinogenic, often involve a monooxygenic system in which cytochrome P450 plays a key role. Phase 2 reactions then usually comes into play, which involve conjugation with some endogenous molecule like glucuronide or some other reactive groups, often inserted during phase 1 reactions, and usually lead to inactive and polar products that can be readily excreted out. Some conjugated products are excreted via bile also and reactivated in the intestine and then reabsorbed. This is known as the enterohepatic circulation. There may be some induction and inhibition of the cytochrome P450 system and other systems also, so that there will be drug-drug and drug-food interactions that may lead to subtherapeutic effect or toxicity of the drug. Pre-systemic metabolism or fast-pass metabolism in the liver or gut wall also reduces the bioavailability of the several drugs when they are administered by mouth. So this is all about the metabolism of the drugs. Thank you. So within this metabolism, the important questions are, what are the different phases of the biotransformation and metabolism? So this may come as a question. So you have to write about the phase 1 and phase 2, what are the different according to the numbers, phase 1 reactions, phase 2 reactions, what will be the consequences, what is the, why this biotransformation is needed, the changes is needed. There may be short note comes from for the cytochrome P450 system, very commonly it can come. Short note can come from the glucuronide conjugation. Short note can come for the fast pass metabolism or the pre-systemic metabolism, and it can be asked about the different metabolism, some examples of the drug-drug interactions that can happen due to these metabolizing enzymes, some examples of the drug induction as well as the drug inhibition. Okay.